Hi, good morning everybody. This is Pradeep Pendiala, Professor of Anesthesiology. Today I am going to discuss with you chronic kidney disease stage 5, that is end stage renal disease. That's the stage when eGFR is less than 15 ml per minute per 1.73 square meters. I'm sure you should be knowing. And what is chronic renal failure? Chronic kidney disease is defined as gradual and progressive decline in renal function, taking several years, leading to accumulation of excess fluid, electrolyte, and waste products. Okay, and chronic kidney disease can also be defined as the presence of renal damage characterized by abnormal excretion of albumin, reduced kidney function, quantified by measured or estimated glomerular filtration rate, which is less than 60 ml per minute per 1.73 square meter, that persists for more than 3 months. That is the stage when chronic kidney disease is diagnosed. And what are the causes of chronic kidney disease? I'm sure you know: diabetes mellitus, hypertension, polycystic kidney disease, chronic or acute glomerular nephritis, systemic lupus erythematosus, and interstitial nephritis. And you should be knowing what are the various stages by which you define stage 1, 2, 3, 4, 5 of chronic kidney disease. Normal eGFR, E means estimated, is normally more than 90 ml per minute. Stage 2, it is between 60 to 89. Stage 3, it is 30 to 60. Stage 4, it is 15 to 30. It goes on decreasing by half. And stage 5 is less than 15 ml per minute per 1.73 square meters. And you should be knowing what are the clinical manifestations in chronic kidney failure, and what are the changes in electrolytes, hematological, pulmonary changes, gastrointestinal changes, CNS and cardiovascular disease changes, cardiovascular system changes, endocrine and neurological changes. Neurological changes are also known as dialysis disequilibrium syndrome or dialysis dementia. I'll talk to you more about it later. And you should know these things and what are the pharmacokinetics and pharmacodynamic changes in chronic kidney disease, and how you have to give induction agents and which neuromuscular blocking agents should be used and why. That is very important. And analgesic agents, what you should do, give, and why. And you should also know, in case kidney preservation is used for kidney transplantation, renal transplantation, what are the various kidney preservative solutions? They are urocolin solution, University of Wisconsin solution, histidine, tryptophan, ketoglutarate. Histidine acts as a potent buffer, tryptophan acts as a membrane stabilizer, and ketoglutarate improves ATP, adenosine triphosphate. Talking about the drugs which we normally give for such patients are definitely sodium bicarbonate. Now you will ask why. It's supplemented, as it has been seen that chronic creatinine clearance goes down by 1 ml per minute per year when you are using sodium bicarbonate. If you don't give sodium bicarbonate in chronic kidney failure patients, it goes down, creatinine clearance goes down more than 2.5 ml per minute per year. So that's why we give. And whether it is there or not, we normally give antihypertensive. Clonidine normally is given. It's a centrally acting alpha-2 agonist. It works wonderfully well. Clonidine is given alone or together with other medications to control and treat hypertension, which is normally there in chronic kidney disease patients. Incidentally, clonidine is a drug. It has a negative inotropic effect. So you have to be careful. Although it is a vasodilator, but in congestive heart failure, it may not work. Telmisartan is normally given for chronic kidney patients. You should not give it on patients who are pregnant, and especially in the last 6 months of pregnancy, that can cause injury to the fetus or even death, serious injury to the fetus. And telmisartan is wonderful, useful drug. It is angiotensin receptor blocker. It is used to treat high blood pressure, heart failure, and diabetic kidney disease. Calcitriol is usually given. What is calcitriol being given in CKD patient? It is 1 and 125 dihydrocholecalciferol. So it is a hormone rather which binds to in vitamin D receptors, which then increases the expression. And calcitriol is an active metabolite of vitamin D, which is used to treat hyperparathyroidism. And hyperparathyroidism invariably will have hypocalcemia. That's why we give. And erythropoietin. Erythropoietin is also given very frequently. Erythropoietin is a glycoprotein hormone naturally produced by the peritubular cells of the kidney that stimulates RBC production. Renal cortex peritubular cells produce most of the EPO. EPO is erythropoietin. And incidentally, PO2 decrease, partial oxygen tension decrease, stimulates the production of EPO, erythropoietin. And hyperkalemia is, we are worried as an anesthetist in CKD patient. Whenever there is hyperkalemia, you may have to reduce it. Normal thing is sliding scale of insulin. If the blood sugar is 201 to 250, we give 3 units. 251 to 300, we give 5 units. Similarly, more than 400 milligram per deciliter blood sugar is found, we have to give 15 units of regular insulin IV. Incidentally, when you treat the blood sugar, automatically hyperkalemia is automatically treated. And the blood sugar is incidentally less than 100 milligram per deciliter, you should never give insulin. Insulin should not be given. Obviously, it's as it is the lower side of blood sugar. And hyperkalemia automatically gets improved by the administration of hypertonic glucose. What is hypertonic glucose? 50 ml of 50% dextrose. Okay, 50 ml of 50% dextrose, that is to be given. The moment blood sugar is controlled, automatically hyperkalemia disappears. Otherwise, normally we give sodium bicarbonate also to decrease hyperkalemia. That is, if the pH is more than 7.4, we should not give. If it is less, we can definitely give to reduce hyperkalemia. Sodium bicarbonate. We give normally 50 milliequivalent. That is in 1 ampule. And we also give calcium gluconate. That is 1 gram IVP. IVP means P means push. Particularly if the ECG is showing hyperkalemia. Okay, normally. And you should also know that why do we have AV fistula in these patients? Normally we have AV fistula to facilitate hemodialysis, to keep the vessel open, and we can do hemodialysis comfortably by AV fistula. This AV fistula is a connection that is made between an artery and a vein for dialysis access. Okay, 2 such options are there for creating AV fistula. First is brachial cephalic fistula, and second is brachial basilic fistula. So that is it. And IV fluids, when we give in such patient, we can give normal saline if the sodium level is less than 140 milliequivalent. If it is more than 140 milliequivalent per liter, we have to give half normal saline. So if there is intraoperative hypertension in end-stage renal disease patients during surgery, we should give we should give calcium channel blockers. Better to avoid ACE inhibitors and beta blockers. That is it. And if there is a metabolic acidosis, we can give 1 liter of 5% dextrose with 3 ampule of sodium bicarbonate. And if there is hypernatremia, that's a question which comes very often to the student during Viva. If there is hypernatremia, that means sodium level more than 150 milliequivalent per liter, we should give THAM. THAM is tris-hydroxymethyl aminomethane. Tris-hydroxymethyl aminomethane. That is the preferred solution. And we give large amounts of blood transfusion also in such patient, because invariably there will be lot of blood requirement in all such patients with CKD. And when you give large amounts of blood, what happens? Citrate causes problem. That lowers calcium level. For that, you must give after every 3 units of blood, we must give 1 gram of calcium gluconate. That's how it controls. Calcium level is controlled. And even phosphate sometimes goes down. That time we must give 10 milliequivalent, but 10 millimole IV of sodium phosphate or potassium phosphate. But that has to be given over a period of 1 hour. So, another question which is a favorite from the anesthetic point of view in Viva, you will be asked how the GFR is calculated, eGFR. See, it could be calculated by MDRD eGFR or Cockcroft-Gault method. Now, what is this MDRD? Have you ever thought of it? I'll tell you. And Cockcroft-Gault is usually done. For that, you may have to use some calculator, 140 minus age in years into weight in kgs divided by serum creatinine into 72. That is a thing which gives, by that you can calculate GFR. But if it is an acute renal failure, you may not get this thing correctly. That's very important. And normally, suppose the patient is having 3 times hemodialysis. So what happens? Like on Tuesday, Thursday and Saturday, you should not do the surgery on Monday. It should be, the last hemodialysis should be done a day before surgery. That means on Sunday, that should be there. Desmopressin is also usually given intravenously or subcutaneous in such patient. So, finally, dialysis is done to correct uremic platelet dysfunction. You should always remember the uremic platelet dysfunction is corrected by dialysis. Heparin is usually used in dialysis, and that should be avoided 24 to 48 hours after major surgery for obvious reasons. And I must always say that the 2 opioids which are avoided are morphine and meperidine. Why? Patients develop metabolite like normeperidine and can cause seizures also with meperidine. And with morphine, patient can develop morphine 6-glucuronide, which is highly active metabolite, which could accumulate and lead to prolonged sedation. You should avoid it. You can give other like paracetamol, tramadol, such thing can be safely given, and even fentanyl. Among the neuroblocking agents, the preferred thing is cetirizine, atrakirum and cis-atrakirum. And I did tell you about MDRD. What is it? MDRD is nothing but modification of diet in renal disease. Very few people know, and they may ask you the normal phosphorus level. Normal phosphorus level is 2.8 to 4.5 milligram per deciliter. Thank you for patient listening. This is Colonel Pradeep Pendiala. Bye-bye. Signing off for today. Bye-bye.